All right. Hello, and thank you so much for joining us today. I am Alexis Smith, and I am the International Partnerships and Programs Coordinator for the Office of International Programs, and this is Foundations of Global Health. Foundations of Global Health series, we have global health is a varied and exciting field to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world and with COVID-19 uniting the world to solve an issue, global health has never been more relevant. This year-long programming is designed to feature our experts in the field of global health, KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Each presenter will share their personal journey, educational background, mentors, books and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and I apparently am not sharing the PowerPoint, so that's awesome. 1 second. There you go. Life-changing moments and heartbreaks. We have some objectives for our series. The learner will gain foundational information on pathways into global health and will be challenged to deepen knowledge on equality and mutualism, which garners true collaboration and global health exchange for everyone's equal benefit. The learner will examine existing attitudes around global health so that we at the University of Kansas Medical Center are trendsetters who move beyond the us versus them, haves versus have-not mentality. The learner will be able to appraise global health, including global health research, philosophy, approaches, attitudes, and the varied efforts in the areas of health disparities, health inequities, and community health. So this is our final FGH presentation for the academic year, but we will be back in the fall semester, so look for an email from me. We do have continuing education credit today. I did include the slides in the chat, but just as a reminder, if you are wanting continuing education credit, you need to sign into Zoom with your full name. Conflict of interest, disclosures. And now about our presenter, Dr. Janine Milgas. Dr. Janine Milgas received her MD in 2010 from the Universidad Nacional Autónoma de Nicaragua in Managua. From 2011-2012, she had pediatric plastic and reconstructive surgical training at Fernando Vélez País Hospital in Managua. Then returned to the Universidad Nacional Autónoma de Nicaragua for her residency. After completing residency in 2016, she had a year-long reconstructive and cosmetic dermatology training at Managua's Antonio Lenin Fonseca Hospital. Dr. Nilges moved to the United States in 2019 and relocated to Kansas in 2020. Currently, she is working as a research assistant in KUMC's Department of Physical Medicine and Rehabilitation. She is also studying for USMLE in order to apply for residency in the United States. Dr. Nilges is married and has a 1-year-old daughter, Claire Marie. And now please join me in welcoming Dr. Nilges. There you go.
Oh, thank you and hi everyone to be here. I'm happy to share this moment with all of you. Thank you to be here. And today I want to share with you some information about breast cancer in Nicaragua and healthcare system. To start with this presentation, it is very important to understand the whole concept, the big picture of what is a healthcare system, especially for a Latin American country. Next, please. So understanding breast cancer in the region in Las Americas. As you can see in the picture, Latin America is an ethnic and cultural diverse population. We have more than 40 million of indigenous people in the Americas, starting in Canada and going through Central America and South America. we have also a lot of experience and lessons to share with the world that are good about our health system. Each country have a different health system. By example, the fears or the best healthcare system in the region is Costa Rica. It's just next to Nicaragua. Then followed by Panama, and number 3 is Nicaragua. So this is a contrast if you see that the ranking is so good for countries like Nicaragua or Panama. But when you go and see healthcare, resource, or access for women and children, you see the opposed. But to understand this, let's go with a small example. Here in this graph, as you can see, Haiti is number 1 for ranking like poor country about poverty, followed by Nicaragua. And when you see this, it's easy to understand that the statistical data provided by WHO, which means World Health Organization, and WHO, Pan American Health Organization, which are the both bigger organizations that pretty much rule the whole continent, had data that say for each case or each death per 2.5 new cases, and compare with Canada and the United States, where for each death for or per 6.5 new case is totally understandable, because the access to resource and cultural education help these women to detect breast cancer early. And it's important to have in our mind that there's 3 important keys for breast cancer. And this is self-examination, access to a professional healthcare provider, and also a mammography. These 3 resources are the key for a woman to detect breast cancer in the early stage and survival. These 3 keys are hard to access in this country, Haiti, Nicaragua, and Honduras, for different political and economic reasons, and even cultural reasons. So Las Americas is mostly composed by Latin American countries or Spanish speakers, but each country, each region is different, cultural and political. That's why each country has its own healthcare system. And talking about his own healthcare system, most of them are 60–70% different about how people can access to a public hospital or healthcare provider. We still have the system about insurance or social security, but most of the continent is public health. That means you can go for free. That's the good thing. What we could say 80% of the population is happy with that. But the bad thing with that is an overwhelming number of people going through a small number of public hospitals. So there's a long waiting list for these people to be seen by a specialist or for a mammography or wherever they need. That's why we have in Latin America more than 118,000 hospitals, starting Mexico and finishing in South America. We have more hospitals than the US. Brazil have more hospitals than US. They have at least 40% more hospitals than the US. In contrast, here in the US, 80% of the population have access to healthcare system, but Brazil have more hospitals, but only 40% of the population have access to a public hospital, because these hospitals are concentrated in the largest city, and rural people who live in the farms and hills don't have access because distance, geographic issues, and also financial issues. So as you can see, Latin America is composed by different colors or different phases about healthcare. It's very complex to understand how the system works. And each country have his own particular key, how they work in the healthcare system. But it is important to don't forget that health system is compromised by all the organization, institution, and all the resources, that mean elements, that are devoted to produce healthcare actions. And the intrinsic goal of the health system is to protect and improve the health in the people, what is connected with people's health. So even when each country has its own system, all of them have the same goal, but all of them are affected 70% by the social life or political life that each one have. So that is very important to understand why we are so similar, but in the meantime, we are so different in how we look. If you think about numbers, most of the peers or five-star hospital in Latin America, 43% is concentrated in only one country, Colombia. 43% to all the hospital in Latin America. That's a lot. But still Colombia have high numbers about people that don't have access to these hospitals because the system work in a very different way. Because most of them are not public hospital and people don't have the financial resource to pay for a private practice. So that is very important to understand the contrast in access and equality in healthcare for Latin American people. And this will create a big impact in healthcare for women and children. And in this case in particular, we're talking about breast cancer. So next, please. And to understand breast cancer, there's two important things, mortality and survival. There's different factors that will be a big influence for this. By example, if you think about United States and Canada, the rate of mortality and survival is 24% mortality compared with a 14% of survival. Then you go through the rest to Latin America, and then the numbers are going to change. We are talking here 27% mortality and 18% of survival. So they are very close, but in the meantime, different. What makes the difference? Why we share the same continent and similar healthcare system, but numbers are never equal? The reason is because the main thing for breast cancer is early detection. That means healthcare, preventive healthcare, which is still in 2022 a big challenge for Latin American countries, because we are facing different political challenge, some political instability, but mostly cultural issues about how it's supposed to be healthcare for a woman. So all of these are the two main factors that influence or impact more in women's healthcare. And you will always have a high mortality if you don't work in the main factor that is influence in early detection. So mortality always will be high and survival always will be low because of that reason. So the key word for Latin American countries and breast cancer is called education in healthcare prevention. So that's why we see those numbers in those graphs. So I hope with this you have a better idea how the healthcare system works in Latin America. And now we can move to Nicaragua. Next, please. Nicaragua is located geographic in the center to Central America. And we have next in our south border, Costa Rica, which is ranked right now first place in the best healthcare system in the whole Latin America. Nicaragua is number 3. But you can see like black and white if you compare both countries. We're close to ranking because we both share that public system. People doesn't have to pay. What makes the difference is in Costa Rica, you go with a medical provider and he say, you need a mammography. So you go in a month and a half to a mammography because they have enough machines, enough technicians to use the machine, enough personnel, and enough technician, all the resource. If you go Nicaragua, yes, it's free. Yes, we have very good professionals, people that study with PhD and much more, have different specialties. But when we go to the resource, we only have what? 3 machines in the capital for 1 million population. So the waiting list is always super long. That's why even if you go on time, the fact that you have to wait a year for a mammography and then you have to wait another 6 months to see your specialist, delay the diagnosis. So delay that diagnosis, it means delayed treatment. So the government have been trying to improve through many different strategies lately. I can see us like Nicaraguan people, we can see that there's improvement. They have more community clinics. We call that community clinics, and they have more access in rural zone to healthcare than these community clinics. But it's still the fact that we don't have enough machine or technician to use this machine is the reason why still women have the delayed diagnosis. And there's 3 keys that we can identify in Nicaragua. First is cultural issues. We are still very, very conservative about the healthcare by a woman. By example, most of the men doesn't like a male physician to see his wife. And most people like to go for nature or like shaman, we can call that, which is good. They have good medicine, but when they treat patients in non-evidence-based treatment, they delay the diagnosis. And the other cultural issue is people think that if you have something like cancer or gynecologist problem, the best is don't talk about it, because you might have been doing something to get that disease. In some way for us here don't make any sense, but if you go there and you see the whole environment, then you will understand that for the people there, it makes sense that blame yourself to have this or that disease. They don't understand that genetics or might be around chemical that make you have this or that disease. They is just like, you might have been punished for something that you did, so it's kind of shameful. So you don't share that. Then geography. Population is in the south and Occident. Most of the population is there. So most of the resources from the government are there. But then we have the north and the Atlantic coast that for years, even with the efforts to the government right now, is still living very wild. They have a lot of indigenous population and they don't want to mix with the rest of the population. In the Atlantic coast, they don't even speak Spanish. They speak something called Creole English or their own dialectic. So it's very hard to mix the population, and they have their own laws. So for the government, it's been very hard to convince them that take the modern medicine is a good thing for them to do and to go with a doctor. They still believe in gods and spirits for healing. So we have those kind of a struggle about culture and geography. Then the number 3 is economy. In Nicaragua, there's 2 things, especially for women that live in the hills and the farms. If you live by yourself with your kids, you probably have at least 4, 5 kids, and you're the head to the family. And the GDP in Nicaragua is $1 or $1.50 per family. So if you want to go to the doctor, to the capital or a big city, that money that you're supposed to use to feed your family, you will need to use to pay for transportation and food. So a mother have to pick between feed the kids or go to the doctor. So they, of course, feed the kids. Plus they say, oh, I don't feel that bad. I have something in my breast. I feel something, but it didn't hurt me. It's just there. It will go away. Because they have to think in that way. They need to think in that way because they need to keep working to feed the family. And in the other hand, if the woman have a man that in theory support the family, she needs his permission, and they have to see how the family economy is, if they have enough money for her to go, and he won't watch the kids. So she need to find somebody in the community, a relative that can watch the kids, because go to, by example, Managua, if you live in the north, it's a long trip, so you might need 1 day to go. Then next day will be your appointment, and then another day to back. So you're out to your house 3 days. That's too much. So ask your husband for permission to leave your house for 3 days. That's a lot. It's a big deal. It's a big problem. And it's a lot of money for the family. It costs a lot of money. So these 3 things are very challenging. And another is super important in Nicaragua is, by example, we don't have data about breast cancer before 1996. We have a hospital, Berta Calderon, that is the national hospital for women since the 80s, but there's no data. The reason is because we have many political issues, a lot of political instabilities. In the 80s, we went in a war, and then the 90s is what the transition time. And then we have different people in the government that stay in the position of health minister for 3 months, 6 months, because somebody say, oh no, you are corrupt, you're taking the money. It was very, very conflicting times for us. So many organizations, even WHO, stopped support for a while because of that instability and corruption. They send the money, they send machines, they send people for training, but all those resources just disappear in the air. Now it's different. Now there's control in everything, but we're still behind to our neighbors like 25 years because of all that issues. And the data that we have now, starting 1996, it's hard to corroborate. It's hard to know if it's real data, if it's accurate numbers, because the system we have now is a communist system, and they are very hermetic about sharing that kind of numbers, because it's very important for them to keep that for themselves, or they're afraid to lose support if they are not reaching the goals established by WHO or PHO, which is the Pan American Health Organization. So it is challenging, it is hard to get data, it is hard to know the right numbers, But before 2018, we have a lot of non-governmental organization in Nicaragua. And we have some data coming from them. By example, they say every year they get between 900 and 1,000 new cases, just them. But we don't know about the public health system. Most people just go the public health system because yes, we have this organization, but they were just a few. Now they don't even are working in the country anymore, I think. But like you can understand, most of the numbers that Nicaragua have right now are not accurate, and you only can guess that they are higher than what officially the government say. And if you go and you share time there in Nicaragua, then you'll see that yes, these numbers are higher. If you go to a public hospital, you'll see long lines of people because we don't have that system in a computer to make an appointment or you can call. You need to go physical and make your appointment. So it's like 2-3 blocks of people in line to set up the appointment for in the next 8 months, probably. So it is very challenging. So think about all these challenges that a woman have to face, try to be in those shoes and think, I will do that? No. That's why most people just stay at home and go to the shaman or go to somebody that they know that have the same disease, because you can buy many medicine in Nicaragua without a prescription. So you just ask your friend, oh, I have this, what I can take, what I can do, and you do it. You just go to the black market and buy your own medicine. Even now, it's very, the government have a lot of control in medicine. Some in many different kind of prescription, but the black market still work. So that's why there's a lot information that is missing. So it's very hard to give accurate numbers about what's going on. And that's why, please, next slide. And that's why AMSCA Foundation. Back a little bit to the thinking, back a little bit in what I was saying the last slide about if you go down there and you see, you will understand the reality about what a Nica woman have to face in life. And this is I'm saying that because there's something that I can feel and be empathic because it's on me. I'm a Nica woman too, and I had to face almost the same challenge. Starting because my aunt, my maternal aunt, who raised me like a mother, she died by breast cancer. And that's why I was very affected since my childhood about, I didn't understand because I was a little girl, but I felt it. You know, like kid, you can feel, you don't understand what's going on, but you can feel the sadness, you can feel the anxiety. So all that with time, I was getting older, and that helped me to understand what's happening in my family and push me to want to help. And that's why AMSCA was born, because of my family's issues pushed me to want to help, and want to help lead me to be a doctor, and lead me to be a doctor, lead me to do something more. And I decided when I was, I think in my last year of medical school, that I want to study something that really help a woman. I need to really help a woman because I noticed that I was young. I was like, what? I don't know. But I felt since age of 14, I guess, I felt that women, we are more vulnerable than the other groups in the society. So I went to medical school at age 18 and then finished my medical school. And I was thinking in all the things that impact me deeply. And because different experience in my rotation, I decided to become a plastic surgeon. Because one of the things that impacted me the most when I was little is that my aunt had a mastectomy. And you think about a mastectomy here in the United States, let's say you get one. What's your next thought? I need reconstruction, right? But that's a taboo. That's something that is not even in the mind to a Nica woman. They don't even know what is a reconstruction. It's hard to believe or understand, but it's how it is. I have a silly history about people in the hills. I worked it for years because you have to give 2 years of social service. That make working in rural places. And when I met a lot of people and friends. So when I leave the place, some people hear that I was studying to be a plastic surgeon. And people didn't understand what means that. I remember I found one of these patients from the hills in the hospital one day, and she told me, and she was looking at me all weird. I was like, what? She's looking at me. I was just talking, and she was like, looking. And I say, what's going on? And she said, doctor, I feel so bad. I hear you turning a plastic surgeon. I was looking your hand because they say there's gonna be plastic. It's so sad. I was like, no, it's nothing like that. They thought I was like doing something to myself to turn plastic hands. People don't know. It's like that. It's not education. It's just people don't have TV, don't have power. There's a lot of people that still live like that there. They don't have even cell phones. I know a lot of people that doesn't have a cell phone. If you want to communicate with them, you have to call somebody in the community that have a cell phone and then go to the house and communicate in case they have signal. It's not that person have to come down to the hill to a place which is very complicated. So that's how still Nicaragua is in many places. And so by 20 something, I was 20, I think, when I have my first lump in the breast. I have my first biopsy, which was very, very hard thing. And that's what my fears are like cold. And then in my rotation in plastic surgery, I will never forget that I went with my boss to my first reconstruction. And I was able to see with my own eyes how much it means for a woman a mastectomy and how much it means for a woman a reconstruction. And I have a patient 18 years old with a mastectomy, and I hear the mother telling, now what I'm gonna do with you, now you're not worthy of, you're worthy of nothing. Nobody will marry you. And she was just waiting for the surgery in the waiting room, and her mother was telling her that while she was just getting dressed to go to the surgery. Can you have idea that psychological impact? And she was just 18. So all that things made me think that I should look for something more. It's not just the mastectomy. It's not just try to help who I can here. So I start to look and think how I can help more. And that's how AMSCAP was born. Because different times I have those mass in my breast and I thought I was about to die or something, because it's in my family and you're working with this kind of patient. So it was very dramatic for me. And I thought, I like to help. I'm helping as much as I can here at the hospital and with my patient or with anyone that come to me for help. I was like a workaholic, dedicating my whole time just to that. But then I started to thought, what if I die? What if I only have 2 years? What if God is calling me and telling me, warning me right now that you're gonna die? And I say, I need to create something that can last longer than my own life. I have a lot of friends that I know they want to help. So it's better if we do this like a team. That way, if one of us can keep doing, the rest of the team is there to keep doing the job. That's why I decided to create AMSCA with the help to my family and some friends. And I found that it wasn't enough just go and take the patient from the hospital that need the surgery, the mastectomy, and follow up for reconstruction. Because I found more. The more I dig, the more I found. I found so many dramatic history. And I decided to create 5 different programs for this NGO. Was transportation, and other one that we call help group. It was kind of psychological therapy group, because if you are with more people that is facing the same as you feel more encouraged and more confidence to talk what's going on with me, why I feel how I feel, and you find that you're not alone, because it happened to me. The more I told about how I was feeling when I found my fears mass in the breast and I start to talk to people, I feel more supported and with more hope. So that's why I decided to create this group, and it worked. I can tell it worked. Especially women in the hill, they don't have friends. They are too busy, and talking again about geography, the houses are very far away. They are farms, and they don't have time to just hang out with friends. It doesn't work like that. They know each other because they live forever in the same place, but they're not like friends going out somewhere to talk. But with this group, I create for them the opportunity to talk with other people that was living the same situation, and they can feel empathy and find support for somebody that they felt really understand what they're going through in this moment of their life. And that was, I think, the best project that we create like NGO. That was the best. We met once every 2 weeks, and every time it was more people coming. So we have transportation, this group. We also have the mastectomy, and we also provide financial support for transportation and lab tests. And then we have to spread our wings to treatment, because they will give you the chemotherapy. But what about the nausea? What about the pain? Nobody cares. And just think, you have your treatment, your IV treatment, and you have to back home 8 hours in a bus full of people. And you're in a bus, and doesn't mean you are sick. You can be just stand 4 hours, 6 hours. Can you imagine that? Do you have idea how much that means? It's terrible. And probably you don't eat. Most of my patients don't have the money to go, but don't have the money for food. And you can eat wherever you find. You need something that with the specific features, like soft, or somebody just wants something cold. But that's to ask for too much for somebody that have less than $1 to make the whole trip. So we worked very hard to support transportation, and transportation, it means food also for them. And transportation, it means that we talk with we call that cooperative of transportation. There's an association of people that have buses and travel between cities to give us a special price, and also to guarantee to us that this woman will have a seat just for them. That was very helpful and very successful while we run all those projects. And at the end, I was very satisfied. I can tell that I was very satisfied. And we were creating one last project because we were growing and growing. Luckily, we found good people that helped us a lot. And we decided that this woman never had done anything fun in life. Never. They if you ask it, what's your dream? They will say, I don't know. I never thought I should have a dream. What do you mean? So once we start to talk, like Nicaragua is known by the land of lake and volcanoes. And we had two big oceans in each side. We have water everywhere. And so I asked it, do you ever been in the ocean? And all of them, no, I never, ever. I barely been in a river, the one that is close to home. So we make a trip to the ocean, and they were women in 40, 50, 30, but they were acting like little girls. It was an amazing experience. We have a professional photographer for that day, and that was super fun. They never had picture other than like carnet picture, or the picture for graduation for the kids, and a few times in life they had picture. So they never talk in life. They will have a professional photographer taking picture for them. So it was an amazing day. So that's why AMSCAP. So please, next. This is our AMSCAP logo. And what you see right now is the National Hospital for Women with Breast Cancer. And the women you see there said are women taking chemotherapy in those chairs. And this is luxury because these chairs were a donation, but they have to be set there in like 2 hours at least. And other women don't have, or not that lucky to have those comfortable chairs. You think, compare this, the National Hospital, the reference hospital for women look like this, and this is the best compared to United States, or compare what should be, and think that this picture is because we were celebrating that somebody donated these chairs, because before they were in worse condition. So this picture is just to give you a general idea what people have to struggle and how hard it's for them go for treatment. I have so many history of my patients about challenge in their life to go for treatment. So after think about spend, let's say 2 hours, sit there. Do you have done your therapy? Nicaragua is very hot, very, very hot, like always in 90s Fahrenheit, and take a bus back home under the sun and no sit and no food. So this is why AMSCAP. This is the reason why. When I took this picture, it's because I think that we got this donation, but being honest to my heart, this wasn't fair for this woman. They should be in a better recliner at least, because chemotherapy is hard to get. It's hard. You really feel very, very sick. You most of the time can stop to throw up. So now think that you can move to that chair, and you need to think that it's somebody else waiting for you to move because need the chair, if that makes sense. Please, next slide. And this is how a nurse works in Nicaragua. See how she is with a small silver plate, we could call that, or wherever they can find, and put the medication and then go patient by patient. It is very uncomfortable for her to work in this way, but it's what we have. And this is why AMSCAP was born, to improve this situation. And in the picture at your left, then you can see me. And that's one of my lovely patients. Her name, allow me to say her name. I got her permission. Her name is Xochitl. It was one of my fierce patients. And I have grabbed my hair like that because I always have long hair, very long hair since I was little. But to be like showing solidarity with my patient, I had cut my hair like very short hair, and I donate my hair, and she was going to the surgery. So we switched. She had that in the head. So I told her, no, you look beautiful. Let me use this one. I don't look that good as you. This day was after. She was like, one day before her surgery. surgery, her reconstruction that we did, and the other woman is her sister. So this is AMSCAP in summary. Thank you. I think we don't have more slides after this one. But thank you for listening, and if you have any question, please let me know.
Thank you, Dr. Nilges. I know that Alexa is going to lead us in some questions, I think, and also we'll be monitoring the chat. I just want to let everyone know who's on that they can unmute themselves, and this is a conversation, so they can unmute themselves and ask a question directly if they prefer, of course. Wonderful job, so interesting. I feel like we could talk for hours about this. There's so much to kind of dive into, so many different aspects from, you know, the medical care in general in Nicaragua, just your journey. I think one of the big topics you touched on is women's health and how this is just a big issue in global health. And it's great to see like how you just committed to this one area to support it and to help it, you know, during your time in Nicaragua. Now that you're in the States, tell me, how do you see, because that passion is in your heart. So what's, you know, how will you connect the passion you have for Nicaragua and for women's health in Nicaragua and now being in the States? And also, do you see any similarities, you know, now with your time here in the States?
Well, I'm here in the United States, but I'm still working for my country in the best way I can. I'm still supporting, this time not through AMSCAP, but personal. I'm still supporting some of my dear patients because we become family and we're still connected by social media. And that's one of the way. But in the other way, I truly believe that individual help is good, but if you work like a team, then it's better. You can create a bigger impact. So I'm volunteering for Nicaragua Global Health Project with my dear friend Nathan. And we are working right now trying to improve resources for Nicaragua with ultrasound machines. And we have MRIs and tomography scans for the future in Nicaragua. We're looking for donations. We're looking for people who want to come down and know the country and meet the people, because it's impossible to don't go to Nicaragua and don't fall in love with the people. Yes, we have many zoos, but I honestly believe that it's most important, the soul and the spirit in the people, than political or social issues. So that's what I'm doing right now. I'm helping like Jeannine, like individual, but I'm also volunteering to help Nicaragua because we need more technology. That's one of the reasons that is so many women get a delayed diagnosis, because there's not enough resource. There's a lot of professional. They have the capacity to give the diagnosis, to see the people, but they don't have the technical resource. That's one of the challenge for the country. Any other questions?
Thank you so much, Dr. Nilges. One thing that really struck me was the similarities between what individuals in Nicaragua are going through and what individuals, I would say primarily in our rural communities here in the US, are going to with having access to healthcare. Several of individuals, their nearest hospital maybe is several hours away. And when you think about someone needing urgent care, like what are they supposed to do? What about transportation? Again, if it's all primarily in one area, what are people supposed to do? And when you were speaking about if a woman, she finds a lump and she needs to go to, let's say, Managua, she has to take 3 days off, or it's choosing between going or taking care of her family. Unfortunately, that sounds like so many similar stories here in the US, where someone will say, well, I needed to take care of my family, so I put off getting the healthcare that I needed. So it's just how connected we all truly are, even though we sometimes don't think that's the case. I really appreciate you sharing those stories to remind us that we do need to work together to create solutions for everyone.
Yes, we have thinking in the US, now I know a little more about the healthcare system and how people live here. Because if you go to Nicaragua, they would say, oh, if somebody in the United States needs a doctor, they just call the next day they're in the office. But we know it doesn't work like that here either. You have to make appointments, sometimes take a little longer. But the difference is you have options. You always have an option here. In Nicaragua, you don't have option. It is what it is, and that's it. You have to wait, and there's no option. There's only one place. There's no other place that you can go. And there's some private clinics, but too expensive. It's just a few numbers of the general population that can have access. So the rich people in Nicaragua is 10% maybe. So that's is the only people that have access to everything. The rest of the population is going through public health. And for public health for us, it's a long waiting list. Here in the United States, yes, you have to wait. But if you don't feel satisfied, you can always give a bad review. You can always call your insurance. You can always call a different hospital. You can look for governmental help. Somebody will help you. There's a plan for like single mothers. I know there's a lot, there's Medicare, there's a lot of resource. Or the state, they have different plans for women. And there's different organizations. In Nicaragua, we don't even have too much organization working for us. It was just a few before 2018. Then we got some political instability again. And now almost all the non-governmental organizations are not working in the country. So you don't have option other than go to the government help, the public help. So that's the big difference, options we don't have, they don't have over there. Is that help with your question?
Yes.
All right. Any other questions?
So what are your future like goals, dreams? I know you think about the future, and you know, you've, for being so young, you've done a lot. You've been involved in global health at a very, you know, large and even, and I would say even personal. So both the intimate, but also the larger global, you know, and engagement. So what do you see for your future? You know, here, you know, soon and into the future, like long term. What are your goals and dreams?
The main thing for me is being in a position that allow me to help, to keep helping. That's the main thing. So I hope to keep working like a healthcare provider here in the United States, because I miss to see my patient. I miss that a lot. And my plan is through that be able to back to Nicaragua and provide help too. And even I thought, well, if I can do more than Nicaragua, I'll do it. Like I know there's a lot of countries in need, like Mexico, Guatemala, that they need help. Of course, the first place is my own country, my homeland. But that's my biggest plan. Continue my education here, get my medical license, work like healthcare provider, keep helping people like healthcare provider, helping my patients, and try to give back what life gave to me, all these opportunities, all these nice people that I know, and all the blessing that I feel I have in my life through help people that have less than me, especially in Nicaragua. And for now, I think Nicaragua Global Health Project with my friend Nathan is one of the main things that will help me to reach that goal. For now, I don't know, tomorrow, probably I'm going to be working or volunteering for 3 more NGOs, probably. So I feel I have a lot of energy to do that. Is my passion. Is I need it. I need to do that to be happy. It's what made me feel alive. If I'm able to help, everything is fine for me. That's the main thing.
That's nice to hear. And I know your heart because I've talked to you. So I know that that's very true. It's not just words. I have one last question before we wrap up. A lot of the individuals on this call are either interested in global health, either they're students or residents, they want to be healthcare professionals and they have an interest specifically in global health. You yourself speak, at least 2 languages fluently, Spanish and English, and you were trained in Nicaragua, you now live in the States. Can you just speak for a moment about the value and having these international educational experiences to go somewhere other than where you've been born and raised and trained, and just how important that is to these future healthcare providers?
Yes, to me, it is very important, your own experience. Yes, you're gonna learn a lot if you hear other people talking about their experience, if you read books, if you watch something online. Yes, that's very helpful, but it's never that compare that living the experience. Then be there, then know the people, then see with your own eyes. That's the only way that you will really understand and interiorize, put inside to you the spirit to the city, understand why and how these people do this in that way. Why is this situation? Why they do this way, this treatment, or people have to go through this or no. So only when you're there and you live the experience, then you understand and travel out the state. For people that is here, I'm talking about the resident, by example. I have good experience when I was in Nica because we receive a lot people who travel for global health experience. And when they start to talk to the people and this kind of patient, one of the main things that they found helpful for them, that they told me that they think they won't find that in a medical school here in the state, is the experience to give a diagnosis without using the technology, all the research that they have here in the state. Oh, I have pain in my tummy. Okay, let's go for an ultrasound. My stomach hurt. Okay, let's go for an endoscopy. You can do that in Nicaragua. So when they start to live the experience and share with the patient and other physicians from other countries, they found that there's much more to learn in medicine. It's so rich. There's so much knowledge that people in Latin American country have to share with their residents from medical school from here, from the United States, that they won't believe. They only will see it and agree with me once they travel and they explore that by themselves. Because there's a lot that the Latin American physician have to share with a North American physician, because we practice medicine very, very different ways. You know, when we are in the medical school, we study semiology, and there's two schools there, the French school for the division to the abdomen, and then is the Latin American or Cuban school to the division for the abdomen. There's two, so it's the same for everything. We practice a very different medicine. I mean, we have the same terminology, we have the same protocols, but in the meantime, we live in a different way, the medicine. We live more the community medicine than people live here. Here is more like make an appointment and see my patient and talk to them. I'm very nice and polite, but that's it. It's over. In next patient. In Nicaragua or Latin country, it doesn't work like that. It's more like community medicine. Like, you know, that's your doctor and you will go with him forever and ever. And it's more, you develop kind of personal relation with that doctor. And the way how people treat a doctor is very different than here. Here is your doctor, is a professional that is taking care of your health. But in Latin America, it means something very different for people. It means it's almost like a priest. If just to give an idea, it's somebody kind of holy for them, because is the person who can see you naked, the person who you will tell things that you won't tell to anyone else, and you can trust because that person won't say anything. So it's a very close relationship, really close relationship. And for us, it's very common to get gift from our patient. And when I mean a gift, it can be eggs, it can be a chicken, it can be whatever, because that's how people express their appreciation for the physician. And that's something that I think students here don't live yet with a patient. That kind of relationship, that kind of sense of I belong to my community, to my patients, is very different. It's a very different relationship. And the way how we practice the medicine, like I say, it's not just the community medicine, is the fact that we practice more the Cuban school. Most Latin American practice Cuban school. That means we don't use too much technology. We learn to give diagnosis based in symptoms and signs instead than technology. We just use the technology to corroborate our primary diagnosis. So we are more like that because we don't have too much resource to use. So we need to learn that. We are more like clinical doctors. So I recommend that please, if you have the opportunity to go and travel and live the experience, please do it because you won't regret. You just will try to do it again. That's my appreciation to the situation.
Thank you so much, Dr. Nilges. It's been such a pleasure. We've had a great group on today, and this will be, as you know, it's been recorded. It will also be available for our students, residents, and faculty interested in global health, also our international partners to access and to watch in the future. We're really grateful for everyone who joined us today. Does anyone have any last comments or questions? We've gone over our time a little bit. I certainly appreciate everybody being here today for us. All right, well, happy Friday to all, and to all a good weekend.
Well, thank you. Happy Friday to everyone. Bye. Thank you.
Bye-bye. Thank you.